Hi everyone, welcome to our debate on in-home therapy versus Tele-ABA. My name is Maribel Ortiz and I will be playing the role of the introducer. I am from San Jose, California. And then next we have Wendy.
Hi, my name is Wendy. I'm from Whiting, Indiana. I'll be playing the role of the researcher, and I will be providing information on both Tele-ABA and in-home therapy.
Hi, my name is Yvonne. Yvonne Harada. I'm currently residing in Los Angeles, California, and I will be acting as the role of the illustrator. And I'll be sharing and explaining some visuals related to some of the studies that we will be sharing in this debate.
Hi, I'm Antina Crockett. I am in Chicago, Illinois. I will be playing the role of the fielder, answering frequently asked questions.
Hello, my name is Elizabeth Tambunga. I am from San Antonio, Texas, and I'll be playing the role of the summarizer, where I will be comparing pros and cons in telehealth ABA and in-home ABA.
So for the purpose of our debate, Tele-ABA will be defined as an applied behavioral analyst using telecommunications technology to deliver virtual evaluations, therapy, and educational services in real time over a geographical distance. In-home therapy will be defined as a therapist providing therapy that is conducted at the site where a client resides. Next, we have Wendy, who will be going over some in-home therapy pros and cons, as well as some Tele-ABA pros and cons.
Thanks, Maribel. So for in-home therapy pros, some points we have come up with is that they remain more ethical. There's direct contact between client and therapist. There are also more opportunities for observations as well as the modeling of behavioral techniques because you're conducting the sessions face-to-face. Another pro would be that it's cost efficient, possibly increasing generalization skills to more natural settings. And training parents helps communication between their own children and even improved expected behavior. Some pros for Tele-ABA is that it's effective communication. There's no need for closer relationships. It also helps improve ABA skills of parents. It saves significant miles and commute time to therapy sessions, and it can be in contact as needed by professionals. There's also accessibility to remote and rural areas. Some in-home therapy cons is that intervention could suffer based on parent or family influence. There is lack of time and personal energy of caregivers. And there's developing and or maintaining teams, problems with recruiting and training staff, some traveling costs and time needed for in-home visits, and far distances can affect and minimize supervision time that may cause challenges in treatment fidelity. Some Tele-ABA cons is that technology can limit contact because of no Wi-Fi connection. There's web-based curriculum may not be child-specific, leaving parents to select videos based on level of skills their child may not have. And there's lack of research with ABA. It can also be a potential breach of confidentiality. There's some families that may not have a computer or in rural areas with various weather or storms. They may lose access for days to Wi-Fi. Later in the presentation, we will show and discuss details on research to support these pros and cons, as well as what BACB codes are relevant to these points. Next, I'll turn it over back to Maribel so she can discuss our first compliance code.
Thank you, Wendy. So for our first compliance code, we will be going over BCBA code 2.09, treatment intervention efficacy, specifically focusing on part C, which just states that a behavioral analyst should consider the cost effectiveness of a treatment. So now Wendy will be going over some efficient and cost effectiveness in both in-home therapy and Tele-ABA.
Thanks, Maribel. Some efficient and cost effectiveness for in-home therapy. We looked at a study by Leaf and colleagues titled Advantages and Challenges of Home and Clinic-Based Model of Behavioral Intervention for Individuals with Autism. And in the study, the procedures based upon the principles of applied behavior analysis can be implemented across a variety of settings. There's often confusion about the differences and relative advantages of home versus clinic-based settings. The purpose of the Leaf and colleague article is to provide the discussion on both. An advantage of home-based model is the potential cost effectiveness for parents and service providers. Caregivers do not have to bear the cost and time required for transportation, and the service agency doesn't need to require treatment space. Service agencies do not need to worry about space issues or increased costs in office could occur. Home-based intervention can be more readily be monitored by parents and may result in more accountability of behavior analysis for their services, while protecting against any claims of misconduct. With more accountable therapists, they may be more efficient, their services will be performed. Some efficient and cost effectiveness for Tele-ABA. We looked at an article by Vismara and colleagues titled Telehealth for Expanding the Reach of Early Autism Training to Parents. Telehealth integrates communication technologies to provide health-related services at a distance. This study looked at 12 one-hour-per-week parent intervention program using the telehealth delivery method with 9 families with ASD. The goal was to examine its feasibility and acceptance for promoting child learning throughout families' daily play and caretaking interactions at home. The selection criteria included the following: children no older than 36 months, the same parent in attendance for all video conference sessions, no intensive treatment as defined by 10 or more hours of in-home or center-based intervention during the 12 weeks, and a diagnosis of autism spectrum disorder, as well as internet availability from their home throughout the duration of the study. One notion of cost effectiveness is that 77% of US families now having internet access. These simple intervention aids that parents can access via online modules is easily record and view children's progress across learning goals. The efficiency of the study is noted to deliver specialized services in real time over a geographical distance. It can be accessed at any time of day in any location with basic, inexpensive equipment and uses interactive, personalized features to communicate and share information. I'll now turn it over to Yvonne so she can discuss the Lindengard's slide.
Thank you, Wendy. As Wendy reviewed, Leaf and colleagues' study touched on transportation and treatment space cost effectiveness of in-home therapy, and the Vismara and colleagues' study talked about time efficiency of a 1-hour-a-week telehealth intervention. This graph goes further into comparing the costs of in-home ABA and Tele-ABA therapies. In this study by Lindgren et al., they compare 3 service delivery modes of treatment: in-home therapy, in-clinic Tele-ABA, and in-home Tele-ABA. As we see, the total average cost per week per child receiving functional analysis and functional communication training treatment is significantly lower with home Tele-ABA services. However, family costs are slightly higher than an in-home therapy. The next slide shows the total costs to complete an FA and FCT under each mode of delivery. In this chart, we see that the overall cost to complete FAs and FCTs are similar on a weekly cost basis. However, upon closer look, if you look closer, facility and family costs, which was lowest in the weekly costs for in-home therapy, had jumped to being higher than in-home Tele-ABA after completion of the program. Continuing further, the number of weekly visits needed to complete the FA was similar with all modes. However, in-home ABA required significantly more home visits to complete functional communication training, which may suggest greater time efficiency in Tele-ABA methods for this particular study. This brings us to our next ethical code, which Maribel will review.
Thank you, Yvonne. So for the next part of the BCBA codes, we'll be discussing Part A of Ethical Code 2.09, Treatment Intervention Efficacy, and this just states that behavioral analyst has the obligation to educate and provide clients with the most effective treatment available to them. So now Wendy will go ahead and discuss the behavioral plans in Tele-ABA as well as in-home therapy.
Thanks, Maribel. So for behavior plans in Tele-ABA, we looked at a research article from Ingersoll and colleagues, and it was titled Parent Engagement with a Telehealth-Based Parent-Mediated Intervention Program for Children with Autism Spectrum Disorders, Predictors of Program Use and Parent Outcomes. The background of this article talks about the growing interest in using telehealth to increase access to parent-mediated interventions for children with ASD. However, little is known about how parents engage with these types of programs. The objective discusses data from a pilot study comparing self-directed and therapist-assisted versions of a novel telehealth-based parent-mediated intervention. The method was to randomly assign to receive a self-directed or a therapist-assisted version of Impact Online. Parent satisfaction was collected through post-treatment evaluation surveys. There were 27 parent participants in this study. The mean age of the child participants were 43.26 months. The study found high rates of program engagement among parents with overall completion rates similar to those found in studies of traditional parent-mediated intervention programs for children with ASD. Parents also rated the program very highly in terms of the acceptability of treatment, the usability of the website, overall satisfaction with the program, and the quality of the therapist relationship for the therapist-assisted group. This program was very convenient as many parents utilized the website during times of day when traditional parent training would not occur. This difference may allow families to learn at times that are beneficial to them, such as when kids are sleeping. Further research needed to be explored as this study had a limited sample size. This is a great example of Compliance Code 2.09, Rights to Effective Treatment, because it is designed to help families in need that may not have the necessary means to get their child to a facility for therapy. The behavior plans in-home therapy, we looked at an article by Hastings and colleagues titled Facilitating Factors and Barriers to the Implementations of Intensive Home-Based Behavioral Intervention for Young Children with Autism. This study had 141 UK parents conducting LOVA-style intervention with their young child with autism and were asked to identify factors that acted as facilitator factors and barriers to the implementation of these programs. Parents responded to written questions contained with a questionnaire survey. Hastings and Remington, 1993, argued that barriers to behavioral intervention fell into four main categories: aspects of services and institutions, the nature of the programs themselves, staff factors, and external factors. Emerson and Emerson, 1987, suggested that factors leading to the lack of consistency in carrying out programs included human resources, environmental factors, competing contingencies operating on resident behavior, and lack of professional support. Overall, parents found the team-based approach to LOVA-style intervention highly supportive, but there is a danger that poorly trained staff will be used as no other staff are available. This will tend to reduce the efficacy of any intervention and could result in heavy financial and psychological losses for families. When considering Code 2.09, Rights to Effective Treatment, we have to keep these factors and barriers in mind when implementing intensive home-based behavioral intervention. Now I'll turn it back to Yvonne to discuss this next visual.
Thank you, Wendy. When looking at Compliance Code 2.09, treatment efficacy should be validated and based on experimental research, literature, and scientific support. Wendy discussed Ingersoll and Berger's study on parent engagement of telehealth interventions. As the visual shows here, engagement significantly increases with additional therapist assistance compared to the only self-directed use of online trainings. Wendy also discusses Hastings and Johnston's study of facilitating factors and barriers of in-home low-boss style therapy based on parent acceptability questionnaires. I would like to go back to the Lingard et al. Study to look closer at data gathered on efficacy of Tele-ABA modes on client behavior change. In this visual, we see that the percentage of reduction in problem behaviors is the highest percentage for home Tele-ABA. However, acceptability ratings were the lowest. Some factors to consider are the potential parent bias in behavioral change data with in-home Tele-ABA and lack of in-person support affecting acceptability. In the next slide, we take a look at the Vismara et al.'s 2012 study. The results here show variable acceleration with a number of verbalization and imitative gestures across 9 children with Tele-ABA services. The variability in communication treatment outcomes for Tele-ABA is something to consider based on this study. Continuing on to the next slide, in Wacker et al.'s study, we see the results of in-clinic Tele-ABA modes of functional communication training delivery on destructive behaviors. Across all subjects, significant decrease in behaviors suggests efficacy of treatment methods and modes for Tele-ABA. And our final slide for this section from a 2013 study by Vismara et al., joint attention, imitation, and functional verbal utterances were tracked with Tele-ABA modes of delivery. The results again show notable variability with slight overall improvements. Though more research is needed in the area of Tele-ABA treatment efficacy, using quick visual analysis, we can see that the efficacy of Tele-ABA treatment may be higher with decreasing problem behaviors versus variable results found for increasing social communication skills. Some other factors that may affect treatment will be explained by Maribel in our next compliance quote.
Thank you, Yvonne. So for our next code, 1.06, multiple relationships and conflicts of interest. This just states that if a the behavioral analyst should inform the client of potentially harmful effects of having multiple relationships, and they should try to avoid them at all costs. If they find themselves in a multiple relationship or a conflict of interest, they need to resolve to seek it. And then they should also go ahead and not accept any gifts from the families or the clients, and they should not give any gifts or any type of other services other than the ones that they're supposed to be providing for those families. So for the next part, Wendy will go ahead and discuss different types of multiple relationships and conflicts of interest in-home therapy as well as in Tele-ABA.
Thanks, Maribel. So for relationships and conflicts of interest in-home therapy, we looked at an article by Pullman and colleagues titled Applied Behavior Analysis, Does Intervention Intensity Relate to Family Stressors and Maternal Well-Being? The intense requirements that ABA programs place on children and families are often cited as a critique of a program, although there is little evidence to support this claim. Using Perlin's 1999 stress process model, this study assessed 2 things. One, whether mothers of children participating in a home-based ABA program reported elevated depressive symptoms, and 2, whether ABA intensity related to unmet family needs and maternal feelings of depression, personal strain, and mastery. 41 mothers of children diagnosed with ASD participated in the study. The mothers completed 5 questionnaires focusing on their child's behavior. The results stated that fewer depressive symptoms occurred when children were in more ABA hours per week. However, more personal strain was reported when mothers spent more hours per week involved in child's program. Therefore, ABA intensity, maternal depression, and strain could reflect the time that mothers spend with the child beyond their ASD presentation. Relationships of mother and child or child and family could be greatly affected by the pressures of in-home therapy. We also looked at an article by Leaf and colleagues titled Advantages and Challenges of Home and Clinic-Based Model of Behavior Interventions for Children Diagnosed with Autism Spectrum Disorder. As we looked at this article earlier, the Leaf study discusses relationships and conflicts of interest as potential challenges in in-home therapy. The direct line staff's daily presence in the home can lead to the development of dual relationships, particularly if the staff is employed directly by the family. Some interventionists are directly exposed to details of family life that would not occur if services were clinic-based, such as arguments, the home culture, the cleanliness of the home, and it takes a great deal of clinical skill to maintain this objectivity. Another conflict with this model is that the family may have a greater role in influencing variables related to the intervention, the pressures of caregivers to implement an intervention in a certain way that might not be the best interest to the individual. Lastly, a challenge with support can create a relationship barrier because one client typically has the same therapist over time, and this can be difficult to ensure treatment fidelity, provide an accurate amount of supervision and training, and provide general support for direct care staff. Next, I'll turn it over to Yvonne so she can discuss the side of depression and stress in the ABA therapy.
Thanks, Wendy. As we heard from Wendy, the number of hours spent being involved in a child's ABA program can affect the levels of personal strain experienced by mothers. The more hours a therapist in-home ABA service, the more hours of therapists in-home services receive, the fewer mother-reported depressive symptoms there are. In this chart by Pullman and Schwitzenberg's study, we see that zero mother ABA hours data shows zero rating on the depression rating scale. As mothers' ABA hours increase, we see a significant increase on the depression rating scale as high as 37-point maximum. Though having more in-home ABA therapist hours may reduce the number of direct ABA hours for parents and may help alleviate stressors, there are potentials for risks in other areas. In our next slide, we see some visual examples of potential threats to Compliance Code 1.06. As in-home therapists, the possibilities of getting into sticky, unethical dual relationships may present itself. Some examples include personal relationships with client or family members, providing services outside of therapist's professional scope of practice, doing favors, or just getting too close. This, on the other hand, can more often be avoided with Tele-ABA services, as the service provider would not be physically close enough for these situations to present themselves. Continuing on to the final compliance code, Maribel will discuss environmental conditions that interfere with implementation.
Thank you, Yvonne. So as stated, we'll be going over 5.07 environmental conditions that interfere with implementation. And that just states that if environmental conditions prevent implementation of behavior change programs, behavior analysts must recommend that other professionals assist, and they should go ahead and seek that help. If the environmental conditions hinder implementation of the behavior change program, then behavior analysts seek to eliminate those environmental constraints or identify in writing the obstacles in doing so. Next, we have Wendy, who will be going over environmental conditions in Tele-ABA and in home therapy.
Thanks, Maribel. So for environmental conditions in Tele-ABA, we looked at an article from Wacker and colleagues, and it was titled Conducting Functional Communication Training via Telehealth to Reduce Problem Behavior of Young Children with Autism. In this study, functional communication training was conducted by parents of 17 young children with autism spectrum disorders who displayed problem behavior. Parents received coaching via telehealth from behavior consultants who were located on average of 222 miles from the regional clinics. Parents first conducted functional analysis with telehealth consultation and then conducted FCT that was matched to the identified function of the problem behavior. Parents' assistants located at the regional clinics received brief training in the procedures and supported the families during their clinic visits. FCT conducted within a non-current multiple baseline design reduced problem behavior by an average of 93.5%. While the study shows FCT can be effective, it is important to keep in mind that if any environmental concerns, such as stated in Compliance Code 4.07, it is important to recommend other professional assistance. Some environmental conditions in-home therapy. We looked at an article by Shinkopf and colleagues, and it was titled Home-Based Behavioral Treatment of Young Children with Autism. This study evaluated the impact of intensive behavioral treatment on the development of young autistic children. The treatment was implemented by parents with the assistance of community-based clinicians. Although treatment was unable to be observed directly, parents reported that therapy was developed by Loval's. There was a control group and an experimental group in this treatment. The control group received conventional school-based and brief one-on-one intervention. The results showed children exposed to a course of intensive home-based behavioral therapy were compared at both pre-treatment and follow-up assessments to a matched control group of children receiving standard school-based interventions. The general implication of this study is that intensive home-based behavioral treatment can be implemented successfully in this field without the direct support of an academic center. No matter the setting one is in, it is critical to follow Compliance Code 4.07 and eliminate any environmental constraints that would hinder implementation. I'm going to turn it over to Yvonne so she can discuss home-based behavior treatment on children with autism.
Thank you. Here we have Shinkopf and Siegel's 1998 study, and we can see in this graph that in-home ABA services with high hours of therapy a week show a large difference in initial IQ scores than the school-based intervention group. However, they also seem to show similar overall effects in the behavior change programs. In this study, the environmental conditions of in-home versus school-based settings do not appear to hinder the behavior change programs. Here is a comparison chart in the next slide of conditions that may interfere with behavior change programs between in-home ABA and Tele-ABA modes of therapy. Elizabeth will talk about these components later in the debate. In the next chart from Ingersoll and colleagues' study, we see that the parents with therapist assistance via Tele-ABA services show lower stress, higher treatment fidelity, and self-efficacy, and the children show greater improvements in communication skills. This further supports the idea that more supervision has positive effects on treatment outcomes. However, it does not necessarily have to be in person. Going back to the next slide, Pullman and Schwitzenberg's study, there was a 37-point rating with 30 hours a week of parent ABA hours. Of the 0 to 60 rating scale, over 20 on the rating scale suggests some form of depression. This can be a cause for concern, as depression and stress of family members may hinder implementation of behavior treatment. When using Tele-ABA methods, parents will be the primary persons implementing the ABA treatments. This is something to also keep in mind. However, as we see in the last visual, despite distance, participating parents in Vismar et al.'s studies show 100% of strong agreement in feeling supported in the telehealth or Tele-ABA interventions. Let's now hand it over to Antina, who will be addressing frequently asked questions regarding Tele-ABA.
Thanks so much, Yvonne. So our first question here is, what is the BCBA's ethical responsibility when considering client preference in regards to the use of Tele-ABA? BCBAs must decide whether or not they are capable of maintaining confidentiality, consent, data, and effectively conducting the following: assessment, treatment, intervention, and supervision. I want to touch base more on these points before moving on to the next question. As far as confidentiality, it is the BCBA's responsibility to make sure clients' information is protected. Because individuals are getting assessed, or because parents are having remote meetings, or even therapists conducting intervention plans via web, it is possible that BCBAs and our ABA therapists might violate Ethical Compliance Code 2.06. BCBAs must take responsible and reasonable precaution to protect confidentiality in order to avoid this violation. Consent. BCBAs must first obtain permission from clients or guardian parents of clients for electronic recording or remote interviews, assessments, and treatment. Consent for different uses must also be obtained specifically and separately so that no violation occurs as far as Code 2.05 goes. As far as data, it can be difficult to make sure data is safely stored. Remember, because this information may be saved onto a device that isn't left in the vicinity of the company, it may be an easy target to getting breached. Leaving data collection on your home computer or other home devices or even on paper isn't always the best idea. Think of it this way. If you have visitors, is it safe to say these individuals won't be using any of your devices or won't accidentally find paper collection of data? Being connected to a home network is pretty risky. Being connected to a company's network, however, and leaving data collection at the company is much easier. And it's much safer. So it is the BCBA's best interest to have data collected and stored in a safe location. Moving on to assessing behavior. It is the BCBA's responsibility to make sure they are appropriately assessing clients remotely. Behavior analysts must be aware that some nonverbal cues may be missed while video conferencing with clients. However, it is important to have specific procedure instructions to make sure important variables hasn't slipped through the cracks, which would then allow ABA therapists or BCBAs to gather information on ABC data details needed to create a behavior intervention plan. As far as effective treatment and intervention, remember, all clients have the right to effective treatment, right? Behavior analysts must be comfortable having their therapists conduct interventions effectively. One thing BCBAs need to realize is that it may be difficult or impossible to conduct discrete trial teachings or even errorless learning. Therapists will not physically be there to error correct or complete a step. Take this for instance. If a child is learning to brush his or her teeth using backwards chain method, therapists will not be there to complete the first couple of steps, right? If you tell a child arms up and is supposed to error correct that child within that 0-second delay, who's going to be there to lift the child's arm? Parents, siblings. BCBAs will have to figure out the appropriate ways to conduct these specific teaching techniques while therapists aren't physically there to do it themselves. So if a behavior analyst is not comfortable with coming up with these specific treatment and intervention techniques, then they might not want to have their client to receive ABA services in their care. Lastly, supervision. It is the BCBA's responsibility to make sure they are appropriately supervising therapists. When video conferencing, it is important to model any technique therapists are struggling with as best as he or she can. Because behavior analysts aren't physically there, behavior analysts need to make sure they are doing it in a way that is understood by the therapist. It is the behavior analyst's job to ensure that supervision and trainings are effective and understood by all therapists. Clients simply cannot have effective treatment if therapists aren't effectively delivering the appropriate treatments, right? Moving on to the next question. What is confidentiality issues might arise when providing either in-home or Tele-ABA therapy, and how should these be addressed? Some confidentiality issues include records and data, an issue involving types of treatment, how data is collected, where it happens, and how can these be addressed easily. It can be addressed with informed consent, HIPAA, and keeping information germane. Recordings, service delivery, written and oral reports, data evaluation, and disclosing information to the clinical team. We're going to move on with Elizabeth, who will discuss some key pros and cons points of in-home therapy and Tele-ABA.
Oh, sorry. Thank you, Antina. I will be discussing and comparing back and forth the key points of pros and cons of in-home therapy versus telehealth ABA. The key points I will be discussing are location, convenience, parent training, parental empowerment, and cost effectiveness. In-home applied behavior analysis therapy is for individuals who have been diagnosed with autism and other developmental disorders. In-home therapy provides the ideal setting for teaching children daily household and living skills. It allows the therapist to implement interventions in different settings where behaviors occur. Location. Home sessions are essential for parent training. Not only does this help the parent gain knowledge in helping their child to do the best with the best of their abilities, but home sessions also allows the behavior analyst to observe parent and child interactions that may be reinforcing or serve as an evocative function for problematic behaviors. When a therapist is physically there in a home session, parents can gain immediate feedback from therapists or supervisors in how they can implement the plan and work on appropriate strategies to replace the child's inappropriate behavior. This ties perfectly with Ethics Codes 2.09, Treatment Intervention Efficacy. A therapist that is physically there can go on outings with the family if necessary. The therapist can physically go with the family to the grocery store or to a restaurant if a child is exhibiting inappropriate behaviors. And the therapist can physically help assist with those problematic behaviors by helping to replace them into socially appropriate behaviors. Where in Tele-ABA, the session can only be where there is full internet access, since the therapist is supervising through a video call, meaning that the family can only go places where Wi-Fi is available, or they would have to pay extra to have unlimited internet at any time on their electronic devices. Since there needs to be internet access at all times, this could potentially interfere with Compliance Code 4.07, environmental conditions that interfere with implementation. Convenience. In-home sessions requires therapists to drive to the client's house to implement parent training or to work on independent tasks that need to be worked on in-home. Within home sessions, the parents can get an accurate picture in how to handle an inappropriate behavior by watching the therapist implement a strategy and then having the parent implement and imitate the same strategy. Whereas in telehealth, there will be no accurate picture in how a parent can implement a strategy onto their child, since no actual therapist comes to the client's house. And Tele-ABA is based only on a computer screen. Parent training and parental empowerment. Parent training in-home involves the therapist coming to the house and conducting parent training to help address concerns that the parent may have regarding their child. The therapist is there to explain the functions of behavior and to help the parent understand how to implement the interventions for their child by using language and showing strategies that is understandable to the recipient of those services, stated in Ethics Code 1.05b. Whereas in Tele-ABA and BCBA is only seen through a computer screen, teaching parents and assessing intervention plans only through a computer base. But having a licensed therapist come to your home and showing you how to implement strategies provides more comfort for the parents in knowing that their child will be provided with services that will help them along with other family members in helping their child to the best of their abilities. Cost. In-home session saves parents the time and cost of gas due to therapists coming to the house to implement intervention strategies. Although it is more expensive for in-home therapy, the family does have a licensed therapist physically coming to the house to implement strategies that are beneficial for their child. According to Lindenberg and Copeland, in-home therapy for seeing a child 1.75 hours per week, including staff costs, facility costs, and family costs, all averages out to $275 a week for in-home therapy. Whereas telehealth does cost less, but the child does not get hands-on experience with a certified therapist. Moving on to telehealth ABA. Telepractice or telehealth is seeking to improve a client's health by permitting a two-way real-time interactive communication between the patients and the practitioner through the use of application technologies, video conferencing software, and the internet to enable specialists to consult and deliver services in real time. As far as location, telehealth is a cost-effective system of delivery for ABA providers and clients who cannot meet in the traditional face-to-face consultations. Teletherapy can be done anywhere as long as one has a microphone and a webcam. So typically any smartphone will do. A certified behavior analyst or therapist can talk and consult with you in how to implement strategies for your child's inappropriate behaviors. As previously stated above, in-home therapy, a certified therapist is physically there, whereas in telehealth, the therapist is on the computer or smartphone. But why should that matter if the certified therapist is still giving the parent the ability to implement appropriate strategies to replace the inappropriate behaviors seen? So the only significant difference is therapy is provided through an electronic device, which is still compliant with Ethics Code 8.04, media presentations and media-based services. Telehealth can be more beneficial in an in-home session, since the therapist is physically there, the child may tend to act different and exhibit more appropriate behaviors than usual, especially on outings. This would create an issue and not allow the therapist to see the behaviors that needs to be redirected and replaced. Whereas with teletherapy, the client's mom can put her phone in a position where the child cannot see the device. And this would allow the therapist to observe the child engaging in inappropriate behaviors. The parent could also have headphones in their ears so the therapist can tell them how to handle their child's current behavior. As far as convenience, teletherapy is very convenient, especially since you can have therapy in the comfort of your own home and not have to worry about driving to a clinic or waiting for your therapist to show up at the door or canceling session last minute due to car trouble or being sick. This would be a hassle since you would have to deal with rescheduling and finding a time to squeeze them in your busy day. In telehealth, the parent is in control of the sessions, and telehealth can be set up to revolve around the parent schedule. Since schedules can be so hectic and parents having other children to consider, it may be difficult for a parent to drive her child to therapy and revolve around therapy schedules, or having to stay in the same room as their therapist and their child for hours for parent training to occur. In telehealth, the parent is implementing the strategies. Parent training and parental empowerment. Parent training in telehealth allows the parent to be the initial provider in implementing the treatments, all with a certified therapist by their side. Since the parent deals with the child the majority of their lives, it is crucial for the parent to feel confident and comfortable in implementing strategies to their child, which can be done since a certified therapist is giving instructions and telling the parent how to cope and handle the child's inappropriate behavior. In-home therapy, according to Leaf and Ferguson, parents and siblings may feel burdened or parents may feel overpowered since the therapist is mainly implementing the plan. Since interventions are in-home for several hours a day, the presence of the therapist may be viewed as an intrusion on the family's privacy. With the therapist always being in-home and communicating with the families about their child's needs and wants, the parents can start to feel more comfortable around the therapist, and this can lead to a dual relationship, which would be in violation of Ethics Code 1.06, multiple relationships and conflicts of interest. According to Leaf, logistics of home-based module, travel time, distance between locations, and cost of travel may create a potential problem with supporting staff, since it's more difficult to ensure high degrees of treatment fidelity, provided an adequate amount of supervision and training, while providing a support for direct care staff, which simply means with therapists being spread out in different locations, it unfortunately can minimize the time that supervisors can observe the therapist, which this could then violate the code 5.04, designing effective supervision and training. Since the supervisors have a variety of therapists to see that are scattered throughout the town, this may lead the supervisor to supervise using video conferencing. If the options of video conferencing a supervisor in an in-home session are due to supervisors being spread out too thin, and therefore it can't make it to supervise in an actual in-home session, then why not just stick with telehealth, where everything is online and the training videos for parents are available at any time of the day for them to reference back on when they are not live with a supervisor or therapist. Telehealth is more beneficial and sufficient in this scenario because the staff was limited on how they could supervise, whereas telehealth wasn't limited. It was a choice for the parents to choose telehealth. And the staff aren't spread out thin since everything is done through a web-based technology. This leads to Ethics Code 8.04, media presentations and media-based services. Telehealth is able to provide parents with training videos that a parent can reference back to at any time they want. They can also set up a call to speak to a supervisor through video conferencing and not have to worry about the supervisor being stressed in an in-home session because they may not have enough time to fully supervise the client. As far as cost, the cost for telehealth is significantly cheaper than in-home therapy, where home sessions can cost $275 a week for 1.75 hours, and telehealth costs up to $155 a week for the same amount of session time. Telehealth also provides parents with different websites and videos to look at on training. Telehealth saves parents money and provides the parents with support and instructions to help their child to the best of their abilities. Since parents are the ones who are with the client the most, they should be taught how to implement strategies, and what better way to do it than having a certified therapist on a video call, giving you and showing you interventions to use on your child that will only be beneficial to them. I will now pass it off to Maribel with closing remarks.
Thank you, Elizabeth. We hope you enjoyed our debate and took away information regarding the differences and similarities of Tele-ABA and in-home therapy. Thank you for your time, and we hope you enjoyed.